bariatric surgery or weight loss surgery. As a part of becoming the center of excellence, also as your magnet hospital, you have to have a part of the thing is like train, bariatric sensitivity, how to be sensitive to the needs of the people that are suffering from, weight, and how when you start bringing them into the hospital, there's like prejudice that exists, like, hey, this is your own fault, and why are you doing this kind of thing. So even though this topic kind of focuses on the bariatric patients, but I think the rules and the talk kind of applies to almost every individual patient that they come across. Some of them could be pain medication seekers, some of them could be drug addicts, some of them could be psychiatric patients. All of the patients have their own specific needs. This is to reiterate why we are here. Sometimes we get jaded by seeing the same things over and over again. Once in a while, we need to step outside the box and see why are we here, and how to address and to be sensitive to the needs of the patient. So, whenever we talk to any patient for that matter, we have to walk in their shoes to understand exactly what the patient is feeling. And sometimes we will never be able to even comprehend, even after me being in the medical field for like almost 32 years now. Some of the things we'll never understand why people do what they do, and what's going on in their mind, what they're suffering. We can only empathize and feel based on our own personal experience. Unless and until we are on our own in that situation exactly, we'll never understand. So, only thing is, hopefully, with having knowledge of how to understand these people kind of helps. So, walk in the shoes of the morbidly obese person for one day, and you'll understand their suffering. And a lot of us even struggle all of our life. Weight is a lifelong struggle, managing weight. And imagine if you're carrying an extra 40 to 50 pounds on your back. If you don't believe me, so just go to the grocery store and pick up a salt bag, 40 pounds, and start carrying on your back just for like 10, 15 minutes. Exactly. So if they're carrying 100, when we say morbidly obese person, they are carrying at least 100 pounds of extra weight on their body throughout the day. So it's a lifelong process. A lot of times when we take care of other patients with other illnesses, we don't touch them. Very good. As a diabetic patient becomes diabetic, we will give them treatment without touch diabetes. The same thing we don't apply to the patients that are suffering from obesity. It's an illness now. It's a disease according to WHO, and it's a life-threatening if it's not addressed, and it's also genetically related, and sometimes it is multifactorial. It means it is a lot of social stigmas attached to it, and then there are medical conditions, and sometimes it's stress, sometimes it is like emotional eating disorder. So it's not just one thing that you can attribute to. And also as a consequence of once people start gaining weight, a lot of medical illnesses starts to pop up. So the thing is, you have to understand when it comes to obesity, is like most of the experience failure is like most patients have tried almost all the fad diets and pills and all of those things. Before even they come to see me, they have already contemplated having the weight loss surgery at least for 2 to 3 years. It's not, they just don't show up and then, hey, I want to have surgery. So they have worked on it, tried to lose weight, and then, it's especially true for people that have tried, like, the now ketogenic diet is the most popular one. In the 80s, it was like Atkins diet. In the 90s, it was South Beach diet. There's always these things that are going to be there. Unless and until people understand the whole concept of what is food and what is not food and what, how to use it, it's going to be there always. And most of them, almost all of them, suffer from at least 2 to 5 medical illnesses that can be treated by just losing weight. And that's one of the reasons we treat as a disease and do the surgeries. And sometimes it is both physical as well as psychological and physiological. And so sometimes when people do all these weight loss attempts, they never lose enough weight to see the benefit. They may lose 10, 50 pounds, 20 pounds, but they never get to the point where there is enough weight where their medical needs start to go away. That is where kind of surgery comes and helps them. It helps get rid of all the medical needs. The simple example I can give you is people that are diabetics. When we do gastric bypass, we stop all of their diabetic medications, even if they're on insulin, 2 weeks before the surgery. 80% of the patients go into remission, complete remission in diabetes. Sometimes these people are on thousands of insulin in units of insulin. They're on 4 different medications for just diabetes alone. But when we give them the benefit, the medical benefits, then they tend to keep the weight off or go to their life. So, for most people, conventionally, they have diet, exercise, behavior modification, and anti-obesity drugs. Today, I'm not going to dwell into all of those kind of things. And more like why the patients are coming to us and how to take care of them. The surgery is one of them, like I told you, and almost like the failure rates compared to the surgery versus the medical and diet. Almost 95 to 100% of people fail within 2 years if they've gone through just diet alone. And as the farther it goes, they gain the weight most of the time. Whereas surgery, success rate is at 50% in 16 years. But if you break it down, like sleeve gastrectomy, gastric bypass, and lap band, and then the duodenal switch, the percentage of success is close to really high. For duodenal switch is close to 90 to 95% of the people, even after 10, 20 years, most of them maintain the weight. And gastric bypass about 20% failure. Sleeve gastrectomy is like 30% failure. Lap band is about 50% failure. Lap band is what kind of brings it down, why people can, that to 50% at long term. So perception towards bariatric surgery has always been kind of bad. For the longest period of time, people used to say, "Hey, you did it to yourself. It's your own fault. You got to take care of it." The same attitude was there even in medical community. Even the doctors, nurses that took care of them, never, helped them to achieve that. Even when the weight loss surgery came into the picture, and most of the insurance companies called it as a cosmetic surgery and did not cover it. So most of the deaths that used to happen, in the bariatric surgery had a bad rep was because when patients were not being educated, there was no standard of care, and there was no way to take care of these patients in the hospital. A lot of us didn't even know how to handle these patients' needs once after surgery. We didn't know how to recognize complications. And so because of that, they had high, death rate or complication rate. So because of that, there's a bad name already exists. So, and also, this is most people say they should be able to do it on their own for various needs. And also, like I told you, why they have a bad rep, And even among medical community, when I first came to the Methodist 11 years ago, and there was why is Methodist hiring this guy, and nobody had success as well. There's always complications. Patients always end up in the ICU, and their patients, nobody wanted, even the nurses were afraid to take care of the patients. Since 11 years I've been here, we haven't lost a single patient. That, and before, in the first 5 years or so, I used to admit that just because the patients people who had that bad perception, we used to keep them in the ICU for the first 24 hours, just to assure them that they're going to be okay. And now we don't even admit the patients to the ICU the last 5 years or so. I just bring them straight to the medical surgical floor. I think the nurses that have taken care of these patients, they can tell they're some of the easiest patients to take care of now. because the safety profile and education, almost every nurse on the floor knows, like, how safe it is, how less the complications. So we have to, with adequate knowledge, we can eliminate the stigma attached to it. And the people that come to even surgery, we take into a lot of factors into account even before we bring them to the surgery. They go to rigorous medical evaluation, psychological evaluation, and cardiological evaluation if they have to. Sometimes we have to send them to pulmonary, endocrine, and we make sure that they are medically necessary, and then also they have the equipment to psychologically ready to undergo the surgery. And most people would say, like I said, why surgery? The number one thing that every single person asks when they come to the audience, what if I can take away all of the medical illnesses without taking medication? Everybody say, I don't want to get medication. So I've had patients that are like on 10 to 20 different medications, but 6 months, most of them we can get them all of those medications. That's the number one thing. There's no one pill can address all of these illnesses like high blood pressure, sleep apnea, diabetes, and arthritis, urinary incontinence, and infertility in young women that are suffering from polycystic ovary disease and those kind of things. So, as the patient starts to lose weight, their self-confidence kind of improves. A lot of times I've seen patients that are stuck in their emotional abusive marriages because they don't have the self-esteem or self-confidence to get out of it. And I see sometimes people get out of those kind of situations once they've lost weight. Do you have the self-confidence? People have gone and achieved, things that they would not have been able to. You have to hear the different stories, And a lot of now, the risks of the surgeries outweigh the benefits. When the risks outweigh the benefits, the risks are too much and the benefits are less, then that's not a good thing. When the benefits are, higher, than the risks, then that thing has kind of gone down. So because of that, medical treatment is far less effective compared to surgical treatment. So these patients do suffer from physical limitations. That's one of the physical needs all of the time that you have to worry about, like the clothing choices and the seats in the theaters, simple things. And one of my patients recently, he said all his life he wanted to ride the roller coasters and all those things. He had not been able to. He lost 98 pounds. This whole summer, he's gone to every theme park that exists in the state of Illinois. That's what I call it. You get the life back. A simple thing is like some patients think I can sit in my car comfortably. And one lady said that her whole dream was to go to Disney World. And it took her 25 years. And she could barely even walk in the grocery store. She always used to get on the scooter and get around because she couldn't even get that far without getting short of breath. After all these things, she said, she wrote me a letter, and then she could walk the entire Disney World 8 hours straight, not taking. So that's what we got. Like when you give them that capability to get up on their own, but to take away the physical limitations, they're going to be happy. And a lot of times, like the toilet seats is another one, and the showers, people they cannot fit things, and that's why there's a standard like nowadays, like this toilet seat has to be mounted. There is a limitations. The seats that are used to be hanging on the wall, they used to break down. As a part of the requirements of the Center of Excellence, we have to have toilet, simple things like toilet seats, they have to be mounted on the floor that they don't fall and break down. And personal hygiene, one of the things that I always get caught, patients don't think of, they say, Dr. Salimath, it's personal, I tell you, I can wipe my butt now. Simple things, we take it for granted. A lot of these people cannot even, take care of themselves in a personal hygiene. Those simple things kind of becomes, or bend down and tie their shoelace. those becomes challenging for these individuals. And a lot of social discrimination exists. Humans are the most prejudiced, I think, creatures on the earth. It doesn't matter. You have a bad accent, or you walk on limb. We joke of, obesity is one of the things that they use as a prejudice in social discrimination. Sometimes people don't get hired even though they're qualified well for the job. And promotions at workplace, they don't get hired. They don't get the promotions. It's used as a discrimination. So social discrimination exists, and also they're like a social stigma. They're the stupid kind, But 80%, if you ask all of the people that are taking data, then they will tell 80% of them they feel that they've been prejudiced. So, and also economic discrimination. I kind of mentioned to this promotions and hiring, and also when they apply to schools, like there's educational discrimination that exists. So, and there's a quality of life issues. Simple things like getting down and playing with their kids and walking and vacuuming dishes, the daily chores. A lot of times when that happens, they isolate themselves. They socially isolate themselves. They don't get into the social structures, and eventually they become hermits, and then they keep eating and eating. That you guys have seen where people have to go break their walls and to get them out of the their houses and things like that. So why is this? Because you just need to bring out simple thing awareness to their needs, and then also increase the sensitivity to the patients and empathy and compassion, and becoming role models to our patients and to help them build their confidence. When they come here, that they need to come in and say, okay, my God, this place, they never judged me. They took care of me as everybody else, every other patient that came into the hospital. And also, we have to provide the patients like the safe and comfortable environment where they are cared and welcomed. So who are all the people that are involved in the bariatric surgery team? So we have surgeons, nurses, dietitians, bariatrics, and then support staff. These are all, it could be as simple as somebody that is coming to the lab to get their blood drawn, or they go to radiology to get an X-ray done, and when the dietitian sees them for dietary counseling, and they also go to psychologists when they have body weight changes. Even though sometimes body patients have, even though they have lost weight, but when they look at themselves in the mirror, they still see their overweight. And then sometimes they don't know how to respond to how people treat them after they've lost weight. I can give you hundreds of scenarios where their coworkers or their neighbors, all of a sudden they started giving them attention that they had never given them. These people don't know how to react to them. So those kind of things, the behavioral specialists help them. So the surgeon's goal is once the patient decides to have the surgery, and they come and attend the education program, and they come see us, and then we send them to dietary counseling, and also sometimes based on their psychological needs, we just send them to psychiatrists or psychologists to get them cleared. And then also I provide them the information seminar, and also run the support groups, and also follow visits. And most of the time it's most related to the medical issues. And once educating make sure that what comorbid conditions they have, and all of those things we assess, and then we recommend that based on the need, what surgery will work for them. And the nurses also kind of helps with the working with. Sometimes I have to have peer-to-peer interviews with the patient's insurance companies to get it approved. It's sometimes it takes about 6 months to a year. Some insurance companies take 2 years to get the patient approved to bring them to surgery. And it's a very time-consuming process before even the patient comes to the operating room. And the nurses, up front, we have a bariatric nurse who educates the patient about the process. and we'll get them ready for the surgery and prepare them for what to expect, before, during, and after. And then the nurses play a very important role in the hospitals too, and also in the post-operative care. And the nurses, most of the questions the patients have, they call the geriatric nurse line. And the nurse plays a vital role in caring for the patient throughout the journey of the patient, especially in the hospital, to recognize the complications in an early fashion. And also, we have to provide them the adequate equipment, and also communication and listening to the patients is very, very important. And the dietitians, they have to believe that it's a disease rather than, to help them the patient to understand and counsel and instruct the patient to the pre and post-op nutrition. Most of the time, at least at the Unity Point, they have to go through 6 counseling sessions, dietary counseling sessions, before the surgery gets approved. And we hold them accountable. We ask them to bring the journal to before, and then we show them where they can cut the empty calories or right off the bat. And then we have the dietitian, inpatient dietitian, see the patient before, during the surgery and after recovery period, the progression, diet progression, educate them, and then we give them a sample menu. Every time they come in after the surgery, every office visit, the dietitian sees them and help them. And also sometimes the food is used as an emotional thing. So now you take away their emotional crutch. What happens? So they can't go eat the sweets that they like to eat, or the bread or the pasta, they cannot eat anymore. So at that time, dietitian sees the need for the patient to say, this patient needs to go see the psychologist. And our psychologist sometimes talking to the patient says, hey, this patient's eating things that they should not be eating. They're admitting. So it's kind of working as a team that helps to bring the dietitians role. Every person in the puzzle is very, very important for the success of the patient. So the other medical professionals and the psychologists and psychiatrists and they all play, getting the emotional support they need and changing the body image support and those kind of things. So a lot of times their depression kind of goes away and the patient's still on medication, or sometimes they do get depressed and whatever it's supposed to do. When as they lose weight, a lot of times food is eating addiction, just like it's all the gambling, shopping, compulsive shopping, alcohol. All these comes under what's called process addiction. When you take away one addiction, you usually switch from one to the other. So we have to keep an eye on for these individuals to either become compulsive gamblers or compulsive shoppers or alcoholics. So it's a very sensitive issue. So for the first 18 months or so, we closely watch them for all these issues. And so the referring primary care physicians and those kind of people sometimes act as gatekeepers by educating them and treating as not rather than being a gatekeeper, we want them to facilitate, to help the patients to get to the surgery. Kind of thing. So environmental assessment, in the hospital, we have to make sure that patients have large beds, large doors, the things that we can't usually ignore, kind of thing. Toilet seats, and then even the environmental staff, they have to be, when they come in, to help to be compassionate. And then patient needs to feel welcome and dedicate to unit and center. That's why in our offices we have geriatric seats in the waiting room as well as in the patient's rooms. Some of the patients, if you give them these small seats by actually sitting there for half an hour to 45 minutes, it starts to hurt. It starts to become And issues for the bariatric patients, patients having, tell us like, they're most of the time they feel guilty, they're frightened about, they're embarrassed that they're overweight. As we have to, how are we supposed to respond to them, encourage them, and then give them opportunity to open up and discuss their issues and expectations, and you have to encourage them questions, because a lot of times these patients go home without having adequate knowledge. That's one of the reasons, not only for bariatric patients, all the other patients. Sometimes they come back to the ER because they did not understand something. They were afraid to ask the question. A lot of times they nowadays we have case managers. They call the patients back to make sure that they understood. And I send so many times patients, oh, I didn't know what to do with this thing. If you send things home and then they bring it back right there. It's like you sit there and talk to them. You explain to them everything, but they're under so much stress and overwhelming information, just like flying over their head. Sometimes that's why we have to kind of reiterate, and encourage them to feel comfortable to ask those questions. And remember, always you have to remember, the demanding patient is the most frightened patient, because all of us have anxiety. So anxieties come from what? Fear. Fear of what? Fear of unknown. Especially if you're in the hospital. How many people like to be in the hospital? No. Right. So that's the most anxiety-producing situation. When you're nervous, what do? You fidget. And you want to make sure that this thing is working right. So that's what some of these patients do. Even anytime you're on any floor, any patient calling too much, that means you understand they're not calling to annoy you. They're calling because they're afraid. They're afraid of their, something is wrong, those kind of things. So, and they may accept, sometimes they don't ask him. They're the quiet patient. Even if they're everything going wrong, they say they don't even call you because they're afraid that you're going to come and yell at them. So be mindful of when you're asking the patient for equipment. Avoid making remarks about their size and outside the doorway, and treat others as you should be treated, like, what is it, one of the 10 commandments, right? So, speak to the patient in an intelligent manner. Do not, think that they're dumb. Sometimes it's a preconceived notion that, acknowledge what is important, respond to their questions in a timely fashion. Don't ignore them. And treat the patient in a professional manner. Obesity is not a numb feeling. They are humans too, And obesity is not a character flaw. It is a disease. Remember, acceptance happens when we get to know them as human beings, not just as a fat person. Or for that matter, any patient that you're treating. A lot of times, I see this all, on the floor, very demanding patients. They don't want to go home. They're here every 2 hours on the clock. They got they're watching. It's 2 hours. 5 minutes to 2 hours. Now I'm due for my Toradol or fentanyl or whatever. So we get frustrated. We have so many other patients to take care of. They forget that they're humans. Sometimes unless we put ourselves in that situation, we forget and then we prejudice, and sometimes whatever is happening in our personal life, we bring it and then it will be protected on the patient. So that patients know that. So, however, surgery alone doesn't guarantee for the long-term, success of the patient, but it's like support system. And it's done to provide them a constant support system. Their success rate actually goes up. So, in summary, obesity is cannot maintain the weight loss by long term by eating and exercise, alone. And obesity is a disease, and bariatric sensitivity is a process, taking care of that. And also, education and empathy and support is essential tool for both patients and also the medical professionals to make a successful. So, judge me by the size of my heart, my mind, and my contribution to the society. not by myself. Questions? All right. Next time, you guys are going to see, I'm going to talk a little bit more about the medical and surgical aspects of this.